Hi there, my name is Gavino Garay. I am a producer with Reuters based in Washington. Thank you so much for joining our Instagram Live today. I am going to invite a very special guest, Dr. Anthony Fauci, a man who needs no introduction. He's the director of the National Institute of Allergy and Infectious Diseases and the chief medical advisor to the president. I'm going to he's going to be talking to us about the monkeypox outbreak in the US and globally. And we'll just see if Dr. Fauci can join us. All right, just invited. And again, it's the largest ever outbreak of monkeypox outside of Africa. Globally, the CDC has tracked more than 2,600 cases. That's the latest information we're seeing. The US tops the global case count with more than 6,600 cases. Spain has the second highest number with more than 4,500 cases. And I see Dr. Fauci, you've joined us. How are you doing?
I'm doing very well, thank you. How are you?
I'm doing very well, thank you. Thanks again for joining us today.
My pleasure.
So we've just seen reporting from the Washington Post saying that the U.S. is set to declare as early as today the monkeypox outbreak as a public health emergency. Is that something you can confirm? And if not, or if so, what kind of tools would declaring this as a public health emergency unlock to help fight the spread?
Sure. Well, whatever announcement will be made will be soon. And rather than my confirming it, I don't want to get ahead of any announcement, but assuming that we would have a public health emergency, there are several aspects of it that are important. One is really almost, I believe, a statement of how seriously we're taking this. And it's a very important signal to the community that all hands are on deck now with regard to monkeypox, that everybody understands that this is a very high priority. From a practical standpoint, there are some things that can be done more easily, like some of the logistic or bureaucratic hoops that you have to run through when you're getting something through the system. You can often expedite that when you're in a situation where you've officially declared a public health emergency. You might be able to move money around more easily from an account to another account. But in general, from my own standpoint, I look at it as a very important symbolic expression of how seriously we take what is happening right now. And the numbers that you just gave, which are numbers that are growing every day. I mean, every day we get reports. It gets larger and larger. We have over 6,000 now, which on a population basis is very high. Globally, there are about almost 26,000 cases. And this is something that we don't fully appreciate what the entire scope of is. There's a lot we know about monkeypox, but there's also a lot we don't know about what's going on now with this particular outbreak. Most of the experience we've had over decades was in the endemic countries in Central and West Sub-Saharan Africa, where it was mostly, not entirely, but mostly from an animal, a zoonotic jump to human, with some human to human spread, but not to the level of what we're seeing right now, where the community of men who have sex with men clearly are experience the brunt of the burden of disease, not only in the United States, but globally.
One physician I spoke to recently said, who is researching monkeypox, said he thinks the number of cases in the US may be vastly undercounted. What are your views on that? Do you think it is undercounted?
Well, I think the answer to that, the short answer is yes. And the reason one can say that, even though you don't know the exact degree to which it is undercounted, is the fact that when you do testing in the community, the test positivity is alarmingly high. So that tells you just almost as a fact that you're not really getting all of those who are infected. And as you know, whenever you have a disease of this sort, a viral disease, there's going to be a range of people. There are going to be those who maybe are relatively asymptomatic and don't even notice the lesions, to those who notice the lesions and get concerned and get tested and hopefully wind up doing the contact tracing and maybe access, if they're in a group that would benefit from it, to TPOXX. And then you have another group who have a very, very fulminant case that's so obvious. And that's the group that we're concerned about, everyone, but particularly those who have a high degree of symptomatology, of which, not an overwhelming percent, but a substantial percent, some estimated around 10%, have enough excruciating pain and functional abnormalities that they require hospitalization. So you can get anything from a couple of what looks like inconspicuous lesions to a very, very painful experience.
Speaking about those who have contracted this virus, 2 children have been diagnosed with monkeypox in the U.S. There are cases of women with the virus in the U.S., including 1 pregnant woman. How concerned are you about spread to additional groups, and at what stage should additional groups get vaccinated?
Well, I'll answer the second part first. That I think it's a long way, I believe, though I always keep an open mind, to think that you're going to vaccinate the entire population against this. I mean, you always want to keep that in your back pocket. And that's the reason why, when we were concerned about a smallpox bioterror attack, in addition to the Jynneos contracting, which got a certain amount of vaccines of Jynneos, we got 100 million doses of the ACAM 2000 in the stockpile, 100 million doses. You don't want to use that in a population that might be immune compromised because of the higher degree of adverse events in that group. So that's answering the question that if we ever have to, we'd be able to, but I don't think we're going to go there, because I don't think that's going to happen. When I say don't think, I always have a big however. Always keep an open mind and be prepared. The fact that you're seeing it going into a few children, it's more than 2. I think the official report is going to be more than 2 thus far, is that is not really entirely unexpected that you will see some spillover, because you're talking about spread on close skin-to-skin contact. Close skin-to-skin contact occurs, obviously, in an intimate sexual encounter. But close skin-to-skin contact can also occur under other circumstances that have nothing to do with sex. So we haven't seen an amount of that spilling over into the non-men who have sex with men population. And hopefully it'll stay at a very, very low level that you can contain. But you always got to take things like that seriously and keep an open mind that you might see more of that. You don't want to panic people, because there's no need to be overly concerned now. But at the same time that you're not currently overly concerned, you should be currently very observant and currently very careful and currently on top of what's going on and following it very carefully.
The CDC and the FDA advise, with regards to vaccine, advise against breaking from the 28-day FDA-approved spacing between first and second dosing, but we've seen public health departments in the US, the UK, and Canada, some public health departments temporarily rolling out a single dose strategy to protect more people more quickly. What kind of risks are associated with that type of strategy? And are there, what benefits do you think are part of that strategy?
Well, the benefit of that strategy is the rationale for why many public health authorities at the local level are doing just what you said. They have a certain fixed amount of doses that are given to them, and built into that fixed amount is enough for 2 doses per person on a 28-day interval. But when you have such an overwhelming demand in a community, local public health officials understandably have said, let's take our chances and give out as many first doses as we can, that may lead to a delay beyond 28 days. But you don't want to rely just on one dose, because then you might get fooled into thinking that the durability of your protection is long, and we know that's not the case. If you want a high level that's durable, you need 2 doses. Whether you can get away with, instead of 28 days, maybe 2 months or 3 months, it's entirely conceivable, as long as you ultimately get that second dose. You can't say, ultimately the 2 doses.
You spoke about TPOXX briefly earlier. Is NIAID going to run a trial for TPOXX or tecovirimat, the antiviral that helps some with severe symptoms, as you know? And if so, what's the trial length? And would results let the FDA move forward to an authorization that would help them to start dispensing the drug more rapidly?
Yeah, the answer is yes and yes. So we've already started to implement a randomized placebo-controlled trial of TPOXX in the Democratic Republic of the Congo. That is clade 3, I believe, which is different than the clade that is now circulating in the non-endemic countries. We are now have a concept sheet and will be hopefully starting soon when we get the resources to do it. And resource problems are really clear, and we need to get more resources to do actually a randomized placebo-controlled trial here in the United States in the current at-risk population who have gotten infected. You know, it's 3 pills, 200 milligrams or 600 milligrams twice a day for several days in a row. I mean, it's 14 days. So right away, just the therapy alone is going to take 2 weeks. But if by the time you know exactly what the result is, you should be able to get a result if you recruit people right away in a few months. So hopefully we'll get results in a few months from that.
Another question floating around is about possible U.S. production of the Jynneos vaccine. Bavarian Nordic, the Danish company that produces that vaccine, has the capacity to produce 30 million doses yearly, including for the monkeypox vaccine. Do you have any idea about how long it will take to line up a U.S. manufacturer, and if that's underway?
You know, I don't know. I mean, I'm hearing what everyone else is hearing, that they're trying to line up as quickly as possible a U.S.-based manufacturer, but I really would be just guessing to tell you how long that would be, and that would just not be a good idea. So we need to get the facts on that before we talk about it.
Correct. The WHO chief, Tedros Adhanom Ghebreyesus, has recently recommended that men who have sex with men reduce their number of sexual partners to slow the spread of monkeypox. What messaging would you share with high-risk groups to slow the spread?
You know, it's a very delicate, sensitive issue. When you talk about telling people to modify their behavior, there's the risk of stigmatizing a lifestyle, which we've got to really be careful of, because once you start getting stigma in a situation, then that's the big enemy of public health. However, it is not unreasonable, and many leaders in the gay community are saying that until we get enough vaccination for every people at risk, really be more careful with regard to number of sex partners of people that you really don't know, being careful about looking for lesions when you're having an intimate interaction. There's nothing wrong with doing that, as long as you walk the fine line of making sure we don't let stigma get into that.
We spoke to an epidemiologist recently who posed a sort of layered approach at fighting monkeypox, and suggested that getting some of the messaging from public health to some LGBTQ plus organizations that some of which have been historically underfunded, but to get them to convey them, do some messaging. What's your view on having a more tiered approach at fighting
Yeah.
this?
Oh, absolutely. I think the four pillars that we have diagnosis, we have vaccines, we have treatment, and we have an absolute necessity to outreach to the community. And you outreach to the community not just by direct outreaching, but by employing the community leaders in the MSM cohort of population to really get the message across to their own colleagues, friends, lovers, and what have you, rather than something from above. So engagement of the community has always proven to be successful. Way back when we were doing that 30 plus years ago with HIV, engagement of the community is absolutely critical.
Can you put a number on, the House Democrats in Congress have asked for north of 21 billion to fight this outbreak. Can you put a sort of number on what it will take to fight this?
No, I don't want to do that. You know why? Because when I say something, it all of a sudden goes viral and then it becomes a fact when it isn't a fact. So I better stay away from that.
All right, we'll stay away from that. Can other modes of transmission be ruled out? Things like, and these are a number of questions that I've received, things like from people who are concerned, things like theater work, costume changes, high contact sports like wrestling, water polo, cleaning staff at hotels, handling dirty linens, gyms, saunas, people who work as massage therapists. Are these other modes are these viable possible modes, or is this just kind of like online talk?
Okay, so that's a good question. You always got to make sure when you have an evolving situation like we have now with monkeypox, and like in some respects we had in 1981 with HIV, when we really didn't know whether there were confines and what the mechanisms of transmission were in the summer and fall of 1981 when the first cases were reported. And even what was going on with COVID in January of 2020. When you have an evolving situation, you always keep open the possibility of all the things you mentioned. But you also, on a day-by-day and week-by-week basis, inform people of the data that you have. And right now, we are not seeing any significant spread with the mechanisms that you just mentioned. Does that mean it's not possible that we will see it? Absolutely not. We might. But at this point, we are not, which indicates and suggests that as the time goes by, more and more time, and you don't see it, makes it more and more likely that you won't see it. And that was exactly the case that we had back in the early days of HIV, when we weren't entirely sure, was it passed by casual contact? Well, there was always the possibility, but then as time went by, it became clear that no, it was not passed by casual contact. Then it was, could it be passed by kissing? Well, maybe, but then the epidemiological data showed that it was extremely unlikely that that would happen. So you really got to wait to see how the facts evolve.
The CDC has said that they will have 7 million doses of the JYNNEOS in hand by mid-2023. Do you think that's going to be enough? And at what stage, this is a term you used a lot during the pandemic, at what stage will we start to see a bend in the curve?
I don't know what the answer to that is, but I do know one thing, that what we are trying to do, and I say we, I mean the public health community, this is mostly FDA and CDC and BARDA and the Assistant Secretary for Preparedness and Response, is to try and see if we can actually stretch out the number of doses we have by dilutional techniques, either by giving a lower dose with the same effect or administering a dose by a different route of administration, like intradermal or subcutaneous or what have you, but to try and make a single dose actually be 5 or 6 or more doses. And we'll be doing what's called dose sparing types of studies very soon.
Very interesting. I didn't want to be mindful of your time. I just wanted to say congratulations on your planned retirement. Before we go, could you reflect on your impending retirement, and do you have any specific date in mind?
You know, the press reported that I would be retired incorrectly, that I would be retiring in January 2025. And I made it very clear that I very unlikely will be working in the confines of the federal government by January 2025. I will very likely leave the federal government, but not retire. When I leave, I'm not going to go play golf. I'm going to continue to be doing the things that I'm doing, only in a different venue. When that will be, I really don't know. That can be anywhere from tomorrow till next year. I just don't know. I have to discuss that with my family. I have to discuss that with the White House. I have to do a lot of discussions. But the answer is, I don't know. But when I make an announcement, you'll know.
Okay, well, we'll be sure not to get it wrong. And one last follow-up. You did have heightened security during COVID. Do you have any sort of security concerns post-retirement? I know you haven't declared when, but do you have any sort of security concerns for you and your family?
I do, and I hope that, and I believe I likely will get some continuity of protection after I leave. I don't know how long that will be, but certainly just because one announces next month, next year, or whatever, that you're going to step down, the threats don't necessarily stop, and there are a lot of them.
Well, thank you so much, Dr. Fauci, for joining us, and thank you for everyone who tuned into our Reuters Instagram Live today. Be sure to follow all our social media accounts for the latest on monkeypox and all the news from the source. I'm Gavino Garay. This is Reuters. Take care, Dr. Fauci.
Thank you. Good to be with you.
Bye-bye.
Bye-bye.